Welcome to the Radiology Review Podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review Podcast, your free on-the-go source for radiology board review. On this episode, I will present part 2 of my review of musculoskeletal tumors for radiology board exams. I will make a study guide on this topic available for download on my website, theradiologyreview.com. These study guides are always available to you for free download, so go ahead and find that on my website, theradiologyreview.com. I wish to thank each of you for listening to this podcast, and for those of you who are in crunch time for ABR core exam preparation, now is the time to really bring it, study hard, focus on those areas that will be most high yield for you. I will try to present some more specific tips on subsequent episodes. For now, I wish to remind all of you to not forget about the radiation safety portions of the examination and tell you that Frank Metler's classic book on nuclear medicine has an excellent chapter on radiation safety and radiation regulations that should help you answer just about every question that they might ask you on this topic. So if you haven't seen that chapter yet, now would be a great time to get a copy of Metler, perhaps borrow one from your nuclear medicine department, and read the chapter on radiation safety and regulations. Let's go ahead and get started on the questions and answers. First question. If you see a lytic lesion in a person who is older than 40 years old, what should you consider first? With a lytic lesion in a person who is 40 years or older, unfortunately, the first considerations are metastatic disease or myeloma. Lytic lesions in young adults or teenagers or children have other differential considerations at the top, but once you reach 40 years old, any lytic lesion needs to be viewed with suspicion for either a metastasis or myeloma. Next question. Does heterotopic ossification typically present with early peripheral calcification or early central calcification? Heterotopic ossification classically presents with peripheral calcification. Okay, that is key. Heterotopic ossification presents with peripheral calcification. And you can see that onset of calcification within roughly a month after trauma or injury. Maybe a range would be 4 to 6 weeks to see the calcification start to form peripherally. Malignancy is more likely to present with central calcification. That's a really easy question to ask on the board exams. So remember, malignancy typically starts with central calcification, whereas heterotopic ossification classically presents with peripheral calcification. Next, true or false? Myositis ossificans is a form of heterotopic ossification. This answer is true. Myositis ossificans is typically post-traumatic and presents with peripheral calcifications at an early stage. Myositis ossificans is actually the most common form of heterotopic ossification. The typical location is within large muscles, and again, this is common post-trauma. This is one of the don't touch lesions. So if you see this, you would want to get follow-up radiographs or follow-up CT instead of biopsy or surgery. Okay, don't touch lesion means you do not biopsy or surgically resect. And if you need to do anything, just get follow-up imaging. Next, if you are given a history on a board exam question of a young male with nocturnal pain that improves with aspirin, what bone lesion is this history classic for? When I say this is a classic history, I really mean it. You should absolutely know that this is a classic history for an osteoid osteoma, and this is a very common test question in radiology. A young male with nocturnal pain that improves with aspirin, your brain should be ringing osteoid osteoma. Next, How do osteoid osteomas appear on imaging? An osteoid osteoma presents as a lesion with cortical thickening and an intracortical nidus with variable calcification. Osteoid osteomas are highly vascular on contrast-enhanced imaging. Note that an infection with Brodie's abscess can appear similarly. Brodie's abscess can present with various imaging appearances, but the clinical history would be different with a Brodie's abscess and should point you to a subacute to chronic infection for a Brodie's abscess rather than nocturnal bone pain relieved with aspirin, which would lead you to an osteoid osteoma. Next, what is the most common location of a Brodie's abscess? The answer I am looking for is the tibial metaphysis, and that could be proximal or distal, followed by the femur. A Brodie's abscess can also involve the carpal or tarsal bones. Next, a calcaneal lesion that is bright on T1 weighted imaging and dark on MRI with fat saturation is most suggestive of what lesion? The answer I am looking for is a calcaneal intraosseous lipoma. This is the most common calcaneal bone lesion. Otherwise, an intraosseous lipoma is most common in the bones of the lower extremities. On imaging, look for fat density within the lesion on X-ray or CT, and fat signal with signal dropout on fat-saturated images on MRI sequences to show you that this is a fat-containing lesion. Again, this is the most common calcaneal bone lesion, so if they are showing you something of the calcaneus and it's not something like a fracture, you should automatically be asking yourself, are they trying to show me a calcaneal intraosseous lipoma? Next, the phrase dripping candle wax is a buzzword for what bone lesion? The answer I am looking for is melorhiastosis. Melorhiastosis has an appearance of dripping candle wax that is related to cortical and medullary hyperostosis. If you don't know what this looks like, please look up some images. It is a classic bone lesion. Next, a shepherd's crook deformity is most typical for what lesion? The answer I am looking for is polyostotic fibrous dysplasia. Shepherd's crook deformity is coxa-varus, V-A-R-U-S, angulation of the proximal femur. There are other things that can cause a shepherd's crook deformity, although most classic for polyostotic fibrous dysplasia, and that includes entities such as osteogenesis imperfecta or Paget's disease, along with other entities. Next, true or false? A simple bone cyst is typically eccentric in location. The answer is false. Aneurysmal bone cysts are typically eccentric in location, whereas a simple bone cyst, which is also termed a unicameral bone cyst, is typically centered in the medullary space. Simple bone cysts are most classic in the humerus and are about 90% located within long bones. Remember that the fallen fragment sign, in which a fracture fragment falls dependently with gravity within the lesion, is a sign of a simple bone cyst. Simple bone cysts are frequently first identified after a fracture occurs. Next, what is the most common bone tumor in young adults under 40 years of age? The answer I am looking for here is a giant cell tumor. Giant cell tumors are most common in the distal femur, followed by the proximal tibia, and then the distal radius. Giant cell tumors are also more common in the sacrum and pelvis than in the vertebrae. A giant cell tumor is a metaphyseal lesion with subchondral epiphyseal extension. Next, true or false? Giant cell tumors have sclerotic margins. The answer here is typically false. Giant cell tumors classically show non-sclerotic margins with a narrow zone of transition. Next, true or false? Aneurysmal bone cysts are commonly associated with a giant cell tumor. The answer here is true. there is a high association between granular cell tumors and an aneurysmal bone cyst. Next, a, quote, long lesion in a long bone, end quote, with ground glass matrix centered in the medullary space is most typical for what bone lesion? Fibrous dysplasia is the answer I'm looking for. This is often a long lesion in a long bone and demonstrates ground glass matrix centered in the medullary space. Fibrous dysplasia results from marrow being replaced by benign fibroosseous tissue. Next question. What are two common syndromes associated with polyostotic fibrous dysplasia? The two syndromes I'm looking for are first, McCune-Albright syndrome, and second, Mazur-Brod syndrome. Hopefully I said that close to correct in terms of pronunciation. Mazur-Brod syndrome is classic for polyostotic fibrous dysplasia with myxomas. McCune-Albright syndrome is associated with cafe au lait spots and precocious puberty and or other endocrinopathies to include Cushing's syndrome. With polyostotic fibrous dysplasia, these are both high-yield entities for the ABR core exam, so make sure you know the difference between McCune-Albright syndrome and Mazur-Brod syndrome, and remember that these both are highly associated with polyostotic fibrous dysplasia. Next question. What bone lesion is sometimes referred to as a giant osteoid osteoma? The answer here is an osteoblastoma, which is an osteoid osteoma-like lesion that is greater than 2 centimeters in size. That leads us to the next question. What is the most classic location for an osteoblastoma? The answer I am looking for is that an osteoblastoma is classically located in the posterior elements of the spine. Osteoblastomas are expansile lesions located eccentrically in the medullary space and most commonly seen in teens and young adults. Next, chondroblastomas are most common in which age group and in which location? Chondroblastomas are most common in the epiphyseal region of long bones, or in epiphyseal equivalents, and are most common in individuals under 20 years of age with a male predominance. A chondroblastoma typically presents as a well-defined lytic lesion that may have internal calcification with adjacent metaphyseal periosteal reaction. Next question. What are some of the, quote, epiphyseal equivalents, end quote? Epiphyseal equivalents include the patella, calcaneus, trochanters and tuberosities of long bones, and the tarsal and carpal bones. Next, a NonOspine fibroma is most common in what age group and in which location? A NonOspine fibroma is most common in young patients around the ages of 10 to 20 years old in the distal tibia and femur in a metadiaphyseal cortical location. I'll say that one more time. That was kind of a mouthful. A NonOspine fibroma is most common in young patients, roughly ages 10 to 20 years of age, in the distal tibia and femur in a metadiaphyseal cortical location. Non-ospine fibromas present with a narrow zone of transition and a sclerotic margin with no soft tissue mass or periosteal reaction. If a non-ospine fibroma is small and something like less than 2 centimeters in size, these may be termed a fibrous cortical defect. A non-ospine fibroma may heal with time and will end up looking sclerotic if healed. Next, what are common differential considerations for vertebra plana? This is definitely a high-yield question for radiology board exams, and there is a mnemonic that can be helpful here, which is MELT, M-E-L-T, like the snowman melted in the sun, MELT. The M stands for metastasis or myeloma, E, eosinophilic granuloma, L, lymphoma, and T, trauma or tuberculosis. Those are all potential underlying lesions associated with vertebra plana. That brings us to the final question for this episode. What are common imaging appearances for eosinophilic granuloma? Beyond vertebra plana that I just mentioned, eosinophilic granuloma may show the hole within hole appearance, which results from lytic lesions that are seen slightly asymmetrically involving both the inner and outer table of the skull. That can give you a hole within a hole appearance. Eosinophilic granuloma may also have a button sequestrum and often appears as a well-defined medullary lucency, sometimes termed a punched-out lucency, with or without endosteal scalloping and periosteal reaction. However, eosinophilic granuloma can also appear aggressive and indistinct, but I would focus more on the classic appearances to include vertebra plana, the hole within a hole appearance, and the punched out lucency or button sequestrum appearance. Note also that eosinophilic granuloma can also cause a floating tooth appearance, wherein you see lucency surrounding a tooth that appears to be floating freely within that space. Common locations for eosinophilic granuloma include the skull, pelvis, femur, and spine. Most patients with eosinophilic granuloma will be young, something like less than 20 years of age. Note also that eosinophilic granuloma denotes skeletal involvement of Langerhans cell histiocytosis. That's all for this episode. Make sure and download the free study guide on musculoskeletal tumors for radiology board exam preparation that covers both episode 1 and episode 2 on this topic. If you have suggestions for additional topics, please email me or reach me on Twitter at RadRevPodcast. As a reminder, you can also follow at RadRevPodcast on Instagram, where I am posting near daily tips on ABR core exam preparation, mostly, at least for now, focusing on physics topics. Remember, you have to study really hard to succeed on radiology board exams, so prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.